Hi guys, welcome to the high yield review for the endocrine module. This review is set up as a matching game just like the other reviews. I would recommend that you pause when you see the slide without the answers. Try to answer this first yourself and then unpause when you're ready. Okay, so let's get started. We'll start with some pathology. And there we go. So pause and unpause when you're ready. Okay, so tumor with remnant of Ratkke's pouch. This is your craniopharyngioma. Remember that it is well circumscribed, cystic in nature, with some brown yellow motor oil-like fluid on gross appearance. And if you do an MRI, you're going to see some supracellular calcifications. It's a benign tumor, but it can cause problems by mass effect in the brain. Okay, second is increased urine osmolarity, decreased plasma osmolarity. This is your syndrome of inappropriate ADH secretion. You have so much ADH that it's constantly reabsorbing water, back into the body, back into the blood, and decreasing the plasma osmolarity. Number 3 is decreased urine osmolarity, increased plasma osmolarity. This is where you're just senselessly peeing the water out. So you see this polydipsia, polyuria, lots of thirst, and lots of pee. This is diabetes insipidus. Number 4 is galactorrhea, amenorrhea, bitemporal hemianopia. This is what you see in women who have a prolactinoma. In men, you're actually going to see more of infertility issues along with the bitemporal hemianopia. Number 5, caused by a defect in the diaphragm of the sella that allows CSF to enter the sella and compresses the pituitary gland. This is our empty sella syndrome, and you can see here the CSF, which is red, it can actually get into the sella turcica because, there might be some damage to the diaphragm, and it can really enter in here and push on the pituitary, causing hypopituitarism. Okay, moving on. So thyroid, there we go. When you have increased TSH, and you're not making enough T3, T4, that's hypothyroid or Hashimoto's thyroiditis. When you have decreased TSH but increased T3, T4, that's hyperthyroidism, that's Graves' disease. When you have TSH and T3, T4 levels kind of off the, it could be decreased, it could be increased, but the most important thing what you see is an increased reverse T3, increased RT3. That's a euthyroid 6 syndrome. And remember, this is due to some other underlying cause. We see this in people who have been chronically ill, people who've been admitted in the ICU, and the treatment for this is to treat the underlying cause, and you'll be able to reverse this disease. Okay, number 4 is antibody against TSH receptors. So this is your Graves' disease because you get these antibodies that go and sit at the receptors of TSH, and they actually help you make more. They help you produce more T3, T4. So that's your Graves' disease. 5th is post-viral infection. You'll see you have painful thyroid, granulomatous inflammation. This is your decurvain or subacute granulomatous thyroiditis. 6, you have tall columnar follicular epithelium, so very tall cells, pale scalloped colloid papillae with fibrovascular cores. So this is your B, Graves' disease. When you have very tall cells, they get really tall because they're constantly making a lot of T3, T4. In Hashimoto's, what you're going to see? You're going to see flat cells. So instead of them getting taller, they actually get more flat because they're not making enough T3, T4. 7 is antibody against TPO, and this is what you see in Hashimoto's thyroiditis. This is what keeps you from producing enough T3, T4. Okay, thyroid tumors. So pause and unpause when you're ready. If you have a RET mutation and it's meant to A or meant to B, what you're going to see is a medullary thyroid carcinoma. What's the most high yield thing about this is that if on histology you see these C cells, which are calcitonin producing cells. So if the question mentions anything about a calcitonin producing tumor or C cells, it's your medullary thyroid carcinoma. Second, you have some bodies, ground glass appearance, intranuclear pseudo-inclusions, and nuclear grooves. This classically describes a papillary thyroid carcinoma. This is seen in younger women, and classic metastasis is to the cervical lymph nodes. Next, you're describing pleomorphic giant cells, sarcomatoid spindle cells, and very poor prognosis. So pleomorphic cells with a very poor prognosis, this is your classical anaplastic thyroid carcinoma with almost 100% mortality. Number 4, your PAX8 PPAR gamma gene rearrangement. This is your follicular thyroid carcinoma, and this is what we see in middle-aged women, metastasizes to the bones. And what we see is capsular invasion or vascular invasion, since this is a metastasizing cancer. There is the opposite. There is a solitary encapsulated nodule, which is benign, without any of that capsular or vascular invasion, and that's our follicular thyroid adenoma. So make sure you know the difference between follicular adenoma and the follicular carcinoma. Okay, moving on to parathyroid. Just a quick summary of your MEN1 versus your MEN2A, MEN2B groups of tumors. MEN1, you draw a 1 down your body, so pituitary, parathyroid, and pancreas. MEN2A, MEN2B, you see parathyroid hyperplasia in MEN2A. You see mucosal neuromas and marfanoid body habitus in MEN2B. And then these two down here are common in both. So your pheochromocytoma and your medullary thyroid carcinoma are common to both. Okay, so here are the answers. Hopefully this should be much easier now. Parathyroid hyperplasia, pancreas, and pituitary. That's a 1 down the body. That's a MEN1 or a menin mutation. If you see, pheo, medullary, and parathyroid hyperplasia, that's your MEN2A with the RET mutation. If you see the same things but with marfanoid habitus and ganglioneuroma, it's your RET mutation or MEN2B. And if you see thymic hypoplasia with hypocalcemia, this is your catch-22. Remember your DeGeorge syndrome. Okay, moving on to adrenal. So unpause when you're ready. Decreased cortisol, decreased aldosterone, salt wasting, and virilization, right? So you get no cortisol, no aldosterone, and virilization of the genitalia. That's your classical congenital adrenal hyperplasia or your 21-hydroxylase deficiency. Next is an aldosterone-producing adenoma. This is your Conn syndrome. Third is your Zell-Ballin pattern-nested ball-like neurosecretory granules with positive urine VMAs and positive urine metanephrine, so norepinephrine, epinephrine. This is your pheochromocytoma. You're going to see these Zell-Ballin pattern-nested on histology. And how pheochromocytoma presents is with a classic triad of symptoms in number 5 here. So palpitations, headache, and sweating. This is how the patient's going to present because they're going to have too much norepinephrine, epinephrine in the system. Okay, number 4, small round blue cells, Homer-Wright rosettes on histology, and blueberry muffin babies. So this is our option C, neuroblastoma, and you can clearly see these beautiful Homer-Wright rosettes on histology. Coming to 6 and 7, you have metabolic alkalosis, hypernatremia, hypokalemia, metabolic acidosis, hyponatremia, hyperkalemia. So how I remember this, right? Honestly, just focus on the sodium and you'll be able to answer these. So let's go to the next slide. Let's talk about this. If it's a 21-hydroxylase deficiency, you get absolutely no aldosterone and absolutely no cortisol. So if there is no aldosterone, you will have hyponatremia, right? Because you will not be able to reabsorb the sodium. So the option with hyponatremia is our 21-hydroxylase deficiency. However, with the 11-hydroxylase deficiency, where we block down here, yes, we don't get aldosterone and cortisol, but we still get this thing up here called deoxycorticosterone. And deoxycorticosterone has some mineralocorticoid-like property or some aldosterone-like property. So it's still able to bring in the sodium and secrete the potassium. So what we see is hypernatremia and hypokalemia. Okay, moving on, endocrine pancreas. and unpause when you're ready. D cell infiltrates, insulinitis, it's C, diabetes type 1 associated with HLA-DR3, DR4. If you see amyloid deposits, apoptosis and pressure atrophy of the islet cells, that is your diabetes type 2. If you see watery diarrhea, hypokalemia, and achlorhydria, this is a VIPoma. So we're going to see a bunch of different neurosecretory tumors in this slide, like insulinomas, glucagonomas, VIPomas, gastrinomas. Specifically, this one with the watery diarrhea tells you that's a VIPoma because VIP is the major, GI relaxant hormone. So it relaxes the gut, and it just, you get profuse watery diarrhea. And the hypokalemia and achlorhydria follow. Number 4 is increased gastric acid. So you're making too much gastric acid. This is your gastrinoma. And what you see with this is multiple peptic ulcers. And we call this the Zollinger-Ellison syndrome, where we see multiple peptic ulcers in the presence of a gastrinoma. The reason I highlight this multiple is because if it's Zollinger-Ellison or too much gastric acid, it's multiple peptic ulcers. However, if you have an H. pylori infection, it's usually just one peptic ulcer. Okay, next is our increased blood glucose mass in the epigastrium and comparing this to decreased blood glucose mass in the epigastrium. So remember, if in the presence of insulin pushes glucose into the cells. So insulin would decrease blood glucose, whereas a glucagonoma would release glucose into the blood and increase blood glucose. Okay, so glucagonomas would increase blood glucose. Think of your fasting stage. Insulinoma would decrease blood glucose. One of the things you want to know in insulinoma, if someone comes in with very low blood glucose, you want to make sure, or you want to differentiate whether all the insulin that the body is making, is it endogenous, like is it coming from the body in the case of an insulinoma, or is it exogenous glucose that they probably injected themselves with? And for that, you can look at the C-peptide level. If it's coming from an insulinoma, if it's endogenous glucose, there's going to be increased C-peptide. If it's coming from injected, injected insulin, you will not see the increased C-peptide if it's exogenous. Okay, moving on to biochemistry. So glycogen storage diseases. Okay, so what I would want to do is, just spend a quick 5 minutes to just go through these diseases really quick, because they're not as hard as they appear to be, honestly. So let's look at this. We have glucose. We can push glucose into the cells to G6P. G6P can go to make G1P, and then we can store G1P as glycogen. And then when we need it, we can break down the glycogen and release it as glucose. So what you want to remember is that if anything goes wrong with the synthesis of glycogen, for example, your Anderson disease, you can't make the glycogen, right? So you're going to have higher levels of glucose out here. So more glucose will be left here because you can't store it as glycogen. So what you're going to see is hyperglycemia. And another thing you're going to see here is when you're trying to build a glycogen, glycogen is a very complex, super branched structure. And what we call the limit dextrins, the super, highly branched structure. If you have Anderson's disease and if you are missing this branching enzyme, you can't make those branches to begin with, right? So you're not going to be able to make that highly branched structure, so you will not see any limit dextrins. Comparing, this to the other side, you can't use the glycogen. So you have glycogen, but you can't break it down to make the glucose. So what you see here is hypoglycemia. And with diseases on this side, let's do the opposite of Anderson. So if you're missing the D-branching enzyme, where you can't remove those branches, what you're going to see with this one is you're going to see build up of limit dextrins, so build up of those highly branched structures. Okay. There's another disease that we need to know in the breakdown of glycogen. That's the glycogen phosphorylase disease. There's two types. There's the HERS disease in the liver and the McArdle disease in the muscle. Remember that both liver and muscle store glycogen, However, the muscle only stores glycogen for itself, right? It's selfish, it only uses glycogen for itself. So if we see glycogen phosphorylase missing in the muscle, we will not see any hypoglycemia, okay? The only thing we're going to see here is early exercise intolerance. So cramping and early exercise intolerance. I say early because you use glycogen in the early stages of exercising, right? The first thing your muscle is going to use is the glycogen. So early exercise intolerance and hypoglycemia. Hypoglycemia not as much as you're going to see here with the liver. So early exercise intolerance, cramping, and you're treated by avoiding exercise. The other option, the other place we see glycogen phosphorylase missing can be in the liver, and that's where we call it HERS disease. This is where we see, quite severe hypoglycemia, because if the liver can't break down glycogen, it won't be able to send glucose to the rest of the body. So hypoglycemia, hepatomegaly with HERS. And I guess the last one that you want to know, the most severe one, is our von Gierke disease, or if we're missing G6B phosphatase. Von Gierke disease, there's so much going on with it, so you can read up here. Hepatomegaly, cyanotic baby, hyperventilation. There's a lot of lipid breakdown, so you see a lot of ketones in urine. Metabolic acidosis, so lactate is over 15. I think that's pretty classical of von Gierke disease, the very high lactate. So I think this is the most severe one of them all. And there's one more called Pompe disease. So this is a lysosomal storage disease. Okay, so keep this separate from the other ones we did. This is going on in the lysosomes, and glycogen breakdowns to glucose using alpha glucosidase enzyme. If you miss this, you get if you're missing this enzyme, you see Pompe disease. And really the easiest way to remember this is, remember, Pompe sounds like pump, and the pump of your body is your heart. So in Pompe disease, you're actually going to see very severe cardiomyopathy in kids. And what you also see is glycogen accumulation within the lysosome. So you can see vacuolated, these lysosomes this is what it appears in a child, and this is how it appears in an adult. So try to answer these, and you should be able to answer these now. Anderson disease, we're missing the branching enzyme, so we will not see any limidextrin since we cannot make the glycogen. McArdle is in the muscle, so missing glycogen phosphorylase in the muscle. And no hypoglycemia with this one, or maybe very mild hypoglycemia. And you see those early exercise weakness and muscle cramps. HERS, you're missing glycogen phosphorylase in the liver, and you will see hypoglycemia. Corey disease is you're missing the debranching enzyme, so you will not be able to break down those big glycogen branches, and you will see a build-up of limidextrins. Von Gierke is you're missing glucose 6-phosphatase, and Pompe, remember, pump, and cardiomegaly and cardiomyopathy. Okay. And the second one for biochemistry, so pause and unpause when you're ready. So Prader-Willi is B, very high levels of ghrelin, and ghrelin acts on the NPY AGPR to increase appetite. I just think of New York, I go to New York, I eat a lot, street food and whatever, however you want to remember this. This is the center of your brain that increases appetite. Second is obesity, which is C. With obesity, we make lots and lots of more leptin, right? Because leptin is made by our fat cells. So we're making lots of leptin. However, we are resistant to leptin. Okay, so the body gets resistant to leptin. Normally, leptin acts on the POMC cart to decrease appetite. And I just, the one way you can remember this is you go to prom in a car and you want to, stop eating before prom and lose all the weight and stuff. However you want to remember this. And insulin resistance is option A. So you actually affect the PI3 AKT pathway, decrease endothelial nitric oxide production, decrease GLUT4 translocation to the surface of the cells. And also D, hepatic steatosis, because when you have too much insulin, increases acetyl-CoA, it's going to increase your malonyl-CoA and increased fatty acid synthesis. Okay. Moving on to pharmacology. Diabetes, drugs for diabetes. So take a minute and then unpause when you're ready. Your sulfonylureas, like your glyburide, your izides, these are your insulin secretagogues, right? They help secrete insulin. And what you want to remember is, unfortunately, because they're helping secrete insulin, they will lead to weight gain. Okay, so we don't really prefer drugs that are going to lead to weight gain in someone with diabetes. Okay, so these are second-line agents. Metformin is a really, really great drug. It does a lot of different things, right? It inhibits gluconeogenesis, decreases the intestinal absorption of glucose, and also increases insulin sensitivity. So it acts as an insulin sensitizer, also helps with weight loss. So it's our number one, choice for diabetes. But one of the big things you want to remember with metformin is one of the adverse effects. Lactic acidosis is one of the major adverse effects you want to remember about metformin. Third is your TZDs, your glitazones, like pioglitazone, rosiglitazone. These guys, they bind to the PPAR gamma nuclear receptors, okay, and that's how they exert their influence. They're also not our first line, they're second line agents because of weight gain. So yes, the PPAR gamma binding will help, make the body more sensitive to insulin, but that will also cause weight gain. Fourth is our DPP4 inhibitors. They increase the half-life of incretins. And we also have GLP-1 analogs that act like incretins, okay? And both of these are really good drugs, and they cause weight loss, so they're preferred. And the last one you want to remember is our SGLT2 inhibitors, or gliflozins. Remember the flow, right? Flow, like flow of urine. So gliflozin, flow of urine, they actually work in the kidney, specifically in the PCT, and they block those GLUT transporters in the kidney, or the SGLT2 transporters. What that's going to do is that's actually going to decrease that absorption or reabsorption of glucose back into the body, and instead you're going to now pee out all the glucose. The adverse effect you're going to see with this is because of all that increased glucose in the urine, you're going to have an increased risk for UTI, because bacteria are going to, feast on that glucose. Okay. And these are also preferred in the sense that they do cause weight loss. However, metformin is really our number one choice of drug. Hypothalamus and pituitary. So take a minute and then answer when you're ready. Octreotide is a somatostatin analog. So it acts just like somatostatin. It stops everything, right? Soma, body, statin, stop. So stops everything. So we really like to use it in those tumors that release a lot of like VIPomas, gastrinomas, right? Also carcinoid tumors, acromegaly, where we're releasing or making a lot of growth hormone. So anytime we want to stop something, we're going to use octreotide. Second is our cabergoline and bromocriptine. These are our dopamine agonists. So we're going to use these for hyperprolactinemia. So if someone has a prolactinoma, making a lot of prolactin, we can give them dopamine agonists. More dopamine in the system will inhibit the release of prolactin. Third is bisphosphonates, or our dronates. They are, they inhibit osteoclasts. And you can see here, we can use them for Patch disease, osteoporosis, hypercalcemia. Okay, so we can use this for all of those different things. Remember some of the things when someone takes dronates, you have to sit upright for 30 minutes to avoid that esophagitis. One of the adverse effects of your dronates is that osteonecrosis of the jaw. Number 4 is teriparatide. It's the only drug approved for new bone formation. So this is the only drug that can stimulate our osteoblasts. And this is basically nothing but recombinant parathyroid hormone. Okay. Here, thyroid. So this is not really a matching game, but take a minute to think about the answers. And here they are. So what are the drugs that block at each of these different steps? Drugs that block taking up iodide into the gland, that's a reactive iodide in lithium. Thyroid peroxidase converts iodide to iodine, and this is our PTU methimazole. Organification is again your iodides, PTU, and methimazole. Remember that PTU and methimazole, they are teratogens, so you have to be careful on how you use them during pregnancy. Release of hormone from glands via proteolysis, this is again iodides. And T4 to T3 conversion in the periphery is your PTU, methimazole. Propranolol is actually a really big one. We use propranolol in the thyroid storm because not only does it help decrease the conversion of T4 to T3, which is more potent, it also helps to, slow down your heart and help with the tachycardia. And corticosteroids can also do this. Okay, and that is all. This was a quick, short review. Hopefully you guys enjoyed this. Thank you for your time.